So why do we treat? You know, what are the goals? Obviously, goal number one would be to cure the disease. Well, we don't have that right now. So what we want to do is, when you think about treatment for Alzheimer's disease, there's three things you want to think about. It's function, ability to get around, take care of yourself. Then you want to think about cognitive decline, which is your memory. And then the last thing is behavior. And that's how we end up treating patients with Alzheimer's. And you always want to think about what you're doing with these medications, because there may be a point in time when you want to stop them. And you want to know those are the three things that are going to get affected. And the classic drugs is the acetylcholinesterase inhibitors. And everybody's probably familiar. It's Aricept, it's Exelon, and Reminil or Razodine now are the three main acetylcholinesterase inhibitors. And what they do is, acetylcholine is a neurotransmitter. And you can think about it, when this crosses and hits here, a signal happens, whether it's a memory or a thought. And these go down with Alzheimer's. And so what happens is, this comes across and it gets broken down and recycled. And what the acetylcholinesterase inhibitors do is they prevent this, the breaking down, so that we end up having more of the acetylcholine in the synapse, and we're more likely to trigger a response. And these medicines work. You know, they don't work as well as we all wish, but they work and they help. You know, a lot of times I'll say it's like putting a Band-Aid on it, but it definitely improves the situation, but it's not the expectations that we all want. If you get a pneumonia, we give you antibiotics and the pneumonia goes away. And that's what patients should expect from us for Alzheimer's, but unfortunately we don't have that. And what we do is we get it a little bit better, but we don't make it totally go away. The side effects for most of the cholinesterase inhibitors are pretty much the same. You'll see a little bit of a decrease in appetite, but the biggest one we see is nausea, vomiting, and diarrhea. And those are the biggest one. When Exelon was out, before it was a patch, you just couldn't use it because it caused so many people to throw up. And one of my old partners, he used to get the liquid form. And he used to start off at a drop a day, and then go to a drop twice a day, and then 2 drops. And in about 8 months, he would have the patients on a dose that worked. One of the advantages of donepezil or Aricept is that the 5 milligram dose seems to work from the studies. You could increase it up to 10 milligrams, and recent studies have shown that even up to 23 milligrams. I will tell you, I've yet to have one single patient tolerate the 23 milligram. It's just hard to take because of the nausea, vomiting, diarrhea. If you have somebody who has memory issues and you put them on 23 milligrams and now they have accidents with their bowels and you're spending hours cleaning clothes and cleaning up, it kind of defeats the purpose of it. And so a lot of times we try to push up to 10 on Aricept. If they start to develop symptoms of nausea, vomiting, or diarrhea, we'll cut back to 5 and leave it there. What you don't want to do is you don't want to get into the habit of giving one drug and then using other drugs to treat it. So they get diarrhea and then you give them Imodium. You know, that's when you start. That's how older people end up on 30 different medications, with half of the medicines be treating a side effect of the other medications. So you can see nausea, vomiting, diarrhea. These are the incidents. You can see this is with Exelon pill that actually don't have good data with the patch, because the PDR still has it with the pill form, and you can see 50% of them were getting nausea, with 1/3 of them throwing up. You can see a placebo was 6%, and Aricept was getting about that. The older you are, a little bit more sensitive to the medications, but even in elderly people. This study was in people over the age of 85, and you could see it was more than the placebo, but it was fairly well tolerated. And sometimes if I can't get people to tolerate the 5 milligrams, which is the starting dose, I'll cut it in half for a couple weeks to 2.5 milligrams. This isn't a sprint. You know, you want to get the medications on. So if you have to start off at a lower dose, you start off at a lower dose. But the key is to make sure you get there. I see patients all the time who are started on like the Exelon patch. And they're on it for a year. And the first patch doesn't work. The first patch is to get you used to it. It doesn't work better than the sugar pill. It's the second patch that works, the 9.6. So you have to get there. So if you're taking the 4.6 milligram patch, but you're not you don't try to increase it, well, you're not doing anything. All you're doing is spending needless money. And so it's important to start the medications, but to make sure you get up to effective doses. The other drug is memantine, which is Namenda, which is a drug been around forever. It's been tried on everything. They've tried it in Lou Gehrig's disease. They've tried it in strokes. They've tried it in some of the European studies. It showed that it had a benefit in Alzheimer's disease. Its real benefit tends to be in more of the moderate severe stages rather than the earlier stages. So I tend to, when we first diagnose people, if they just have what we call mild cognitive impairment, a little bit of memory loss, some of the studies show that starting medicines like Aricept don't do anything. So 10 years ago, if you had mild cognitive impairment, I started you on treatment. Now I kind of wait a little bit longer. And usually when the Folstein mini-mental is around 24, 25, or if there's a big decline according to the family, then I go ahead and start the medicine. And if the medicine progresses, is when I tend to add Namenda to the other medications, whichever one they're on. And usually it's about an 18 on a mini-mental. And just to give you an idea, that's when people start to have a little bit of difficulty brushing their teeth, coordinating tasks. That's about when the Namenda tends to offer advantage. You could start it earlier. It doesn't do harm. But it doesn't offer anything. And the thing is, once it's generic, it'll be less of an issue. But if you're spending $200 for a medication that's not offering very much, then you have to rethink it. We think it works through glutamate, which is an excitatory neurotransmitter. So it works different than the cholinesterase inhibitors. And when you put them together, they work better than either drug by themselves. So they're really a good combination drug to be used. But acetylcholine is the number one transmitter that we see a change. But I don't want everyone to think that that's what Alzheimer's is. It's all about choline. You see changes in serotonin, you see changes in norepinephrine, and that's why there's a high incidence of depression, anxiety. You may see somebody who's never been anxious their whole life all of a sudden becomes anxious, and that may be related to the illness as well. So when we talked about what do these medications do, the only reason why I show you this is what happens when you do nothing. And so in 1 year, this person dropped 2 points on a mini-mental. And every point you could think of as losing a little bit of memory. When you gave them Aricept, basically their cognition only dropped a little bit. And you could carry this out for 2 years, 3 years, 4 years, and you see that. And so what happens is when you put them on it, they decline, but they're always better off than the person who didn't get it. And so it's always worth trying these medications. Some people don't tolerate it, and I usually use donepezil or Aricept first. If that doesn't work, I try the Exelon patch. If that doesn't work, then I go to Razodon. If that doesn't work, I throw in the towel. And sometimes when one drug doesn't work, you could retry it later, and it's amazing how sometimes it does work. None are better than the others. It's nice now that donepezil or Aricept is generic, so the cost isn't such an issue. When it was $200 and then you add Namenda, you're talking $400 a month for medications. Now the prices come down dramatically. The first dose, the 5 milligram dose of Aricept works, and so it's a good, the handyman who's good at everything. It's good for that, because if the doctor doesn't know much about Alzheimer's and starts it, even if he forgets to try to go to the 10 milligrams, the 5 milligram works. Well, with the Exelon patch, you have to remember to try to titrate it up to the dose that works.